Good afternoon. My name is Eduardo Sanchez. I serve as the Chief Medical Officer for Prevention at the American Heart Association, and I want to welcome you to this webinar on the 2025 AHA ACC High Blood Pressure Guideline, and we're going to talk today about rural implementation. A couple of housekeeping details. Please use Q&A for questions, the tab. Watch for links in the chat. And slides and recording will be available immediately afterwards on targetbp.org. What we're doing today is translating science into practice. And these are the variety of ways that the American Heart Association does the work it does. And these are the ways that Target BP does the work that it does on top of. We leverage American Heart Association guidelines and scientific statements and the American Medical Association MAP framework to support the implementation of better blood pressure control in practice. The framework is the MAP framework: measure accurately, act rapidly, partner with patients. We assist healthcare organizations in their efforts to improve and sustain blood pressure control with professional education, practice tools, and resources to support that implementation. And then lastly, we recognize healthcare organizations annually with achievement awards by celebrating those that have committed to improvements and have taken strides and made certain progress in the name of better blood pressure control. The learning objectives are listed here. I'm not going to go through those in the interest of time, and you will have those available to you. The speakers will do a little bit more to introduce themselves. We'll tell you right off the bat that three of our speakers, Doctors Jones, Bress, and Commodore-Mensah, were among the writing group, the authors of the guidelines. And we are so pleased to have Jessica Weborg join us to talk a little bit about some work in rural communities. Things I want to say. One is that among the things that make life in rural parts of the United States different from non-rural parts of the United States, many good, some not so good. One of them is that I hope we would agree is not so good, is that mortality in the United States, in rural America, is higher than it is in non-rural United States. Higher rates of stroke and CV mortality, life expectancy is 3 years lower, higher maternal mortality rate. And today, we're going to focus in on one area that could perhaps close that gap. Again, I mentioned how that cardiovascular disease and stroke death are both higher in rural parts of our state. High blood pressure is the most prevalent modifiable risk factor for the development of cardiovascular disease, including coronary artery disease, heart failure, atrial fibrillation. It's also a modifiable risk factor for stroke, dementia, chronic kidney disease, and all-cause mortality. High blood pressure is a component of cardiovascular kidney metabolic syndrome, a syndrome that we're beginning to understand how these things that at one time we thought were different and separate actually all contribute, whether that's cardiovascular disease risk factors, obesity, diabetes, full-blown cardiovascular disease, and kidney disease, all working in a negatively synergistic way to make things even more challenging for patients. The overarching blood pressure treatment goal is less than 130/80 for all adults. And with that, I am going to pass this on to Dr. Dan Jones. Dr. Jones.
Well, good afternoon, and for most of you, it's afternoon, I think, and thank you for being a part of this webinar today, and thank you mostly for being there on the front lines to take care of patients. We know that the practice of medicine is challenging everywhere. but especially these days in rural America is a very tough place to practice medicine. Just as a point of credibility, as Dr. Sanchez noted, I was a part of the guideline writing committee, in fact, chaired the guideline writing committee. But for you, I want to add the real credibility, and that is that I'm a primary care clinician. Even though I've spent the second half of my career in an academic medical center as a general internist, I began my career in 1978 practicing primary care medicine in Laurel, Mississippi, a small town in southeast Mississippi, certainly rural medicine. So I'm pleased to tell you that the American Heart Association is interested in primary care and interested in primary care in rural settings. So thank you for being here today to work with us, to have the information that your patients need in your hands to have better control of blood pressure and a better chance of living longer and healthier lives free of cardiovascular disease, stroke, and hopefully as we get more and more evidence of dementia as well. So the 2025 blood pressure guideline is a joint project of the American Heart Association, the American College of Cardiology, and 11 other participating organizations, including the American Medical Association. Next slide, please. All of the members of the 28 member writing committee are clinicians. These are not pointy-headed people thinking about theory all of the time. All of the members of the committee take care of patients and are interested in how you take care of patients as well. Next slide. So here is the top take-home message from the guideline, and the one that is really the top take-home message from today. I'm going to take the time to read this to you. High blood pressure is the most prevalent, modifiable risk factor for the development of cardiovascular diseases, including coronary artery disease, heart failure, atrial fibrillation, stroke, dementia. And you see that highlighted there. That's an important new finding that intensive lowering of blood pressure reduces the risk of dementia, chronic kidney disease, and all-cause mortality. The overarching blood pressure treatment goal is less than 130 over 80 millimeters of mercury for all adults, with additional considerations for those who require institutional care in a nursing home or similar and have limited predicted lifespan or are pregnant, to different guideline recommendations for pregnancy. Next slide, please. So here it is, the goal systolic blood pressure in 2026, delineated in 2025, is a systolic blood pressure goal of at least less than 130 millimeters of mercury, with encouragement to achieve a systolic blood pressure of less than 120 millimeters of mercury. Now, I know you wonder, why in the world do we keep changing these numbers? It was 140 and gee whiz, that was hard enough. And now you're asking us for 130 and you're even mentioning 120. But here's what we know. Here's what we know is that the further reduction in blood pressure down to the 130, 120 range does indeed lead people to have fewer heart attacks, fewer strokes, less dementia, all of those things that we want to prevent. And one of the, for many years, we thought perhaps it was not safe to lower blood pressure this far in patients, but in all of the studies that have shown this benefit in recent years, all of the participants are older, high-risk patients, patients that you and I feared might not be able to tolerate systolic blood pressures down in the 130 to 120 range. But we know from 8 solid studies over the last 3 or 4 years, it can be done, and it can be done safely. Next slide, please. So a few words about how to evaluate the patient when you do make the diagnosis of hypertension. If the blood pressure is 130 over 80 on a consistent basis, here are some things that you need to think about in your office for evaluation. Next slide. So the first part of the evaluation is just an accurate measurement of blood pressure. I know you get tired of hearing people like me talk about the importance of accuracy, but it is very, very important. Here you see on this slide, and you'll get a copy of this, all of the things that are important in measuring the blood pressure. The rest period is important. The cuff size is important. The resting of the arm and the positioning of the feet and the legs. All of these things make a difference. And as we go lower and lower with recommendations for blood pressure, it's so important for your patients, for your practice, that blood pressure is measured accurately. You see the oscillometric instruments being used, and that's what is recommended certainly for your use in your office. If you still have the old aneroid instruments that are hung to your wall, I encourage you to do away with them and move to using the modern oscillometric instrument to measure blood pressure. Next, a little bit more on measurement in just a moment. Next slide, please. So here are the blood test and the other tests that you need to consider doing in every patient who has high blood pressure. These are unchanged from the 2017 guideline, and most of them are unchanged over the last number of years, with one exception, and that one exception is highlighted here in yellow. That is the urine albumin to creatinine ratio. You just collect a simple urine and ask the lab, rather than doing a standard simple urinalysis, ask them to do the albumin to creatinine ratio. This is simply a test that's a little more sensitive than the serum creatinine level at identifying early chronic kidney disease. And it's important that you identify these patients early for two reasons. One, so you can really pay attention to their blood pressure. And then if you need to refer the patient to a nephrologist for evaluation of the cause of their chronic kidney disease, it's the good time to do that as well. So here's the things that you need to consider doing in your office with a patient with high blood pressure: CBC, serum electrolytes plus a calcium, the serum creatinine with an estimation of GFR, lipid profile. That does not have to be done fasting for this screening test. Either a fasting blood glucose or a hemoglobin A1C, either one of those will do to help with the diagnosis of diabetes. Thyroid stimulating hormone, a urinalysis, and an electrocardiogram. And again, that urine albumin to creatinine ratio. All right, next slide, please. So back to measurement of blood pressure for a moment. We do in the guideline recommend that if you measure the blood pressure in the office and the blood pressure is elevated, then we recommend that the confirmation be done out of the office. You know from your practice that many people have higher blood pressures sitting in your office than they do anywhere else. And so it's important. Two options here. One is ambulatory blood pressure monitoring. Many of you may not have that available to you in your practice, and that's okay. Home blood pressure monitoring does just as well for you, and you can have your patients measure during the time that you're trying to make the diagnosis. Have the blood pressure measured at different times of the day, several times a week. Have the patient keep a recording of that and either send it to you through your electronic health record or some other way, or bring it back when they come back to see you or one of your associates in the office. And so it's really important that the blood pressure be measured accurately, that there be both in-office measurements and there be some out-of-office measurements as well. So if you have a few, like I did in my practice years ago, if you have a few patients who can't afford to buy their own home blood pressure monitor, $35 to $50 in most communities. But if they can't afford that, one of the things that's useful for you to do is just to have a half a dozen or so in your office that you can loan to your patients to take home for a month to measure their blood pressure at home. And then periodically during the time that they're on medications, to allow them to have home blood pressure measurements so that you can make good decisions about modulating the medication doses and so forth. All right, next slide, please. This one's important. A lot of your patients are asking you about, can I depend on the blood pressure that my watch tells me I have? And the answer is no, absolutely not. Cuffless blood pressure devices, especially those on the wrist, absolutely not accurate for measuring blood pressure. Your patients shouldn't depend on those, and you shouldn't depend on those. You should advise your patients to buy a good home blood pressure monitor to measure their blood pressure with an instrument that has a cuff over the brachial artery and is an inflatable blood pressure monitor. Next slide, please. So the other important part of evaluation when you first see the patient, and this needs to be done within the first month or two of making the diagnosis of high blood pressure, is to just be sure the patient doesn't have some form of secondary hypertension. About 95% of our patients have what we used to call essential hypertension and now usually referred to as primary hypertension. We don't really have some specific something we can do other than treating them with medications and with good lifestyle therapy to manage the blood pressure. But everyone needs to be screened. So here's a list of potential things that you need to think about as you're talking to the patient and taking a history. Drugs that they might be taking that would induce hypertension, whether they have the abrupt onset of hypertension or whether it's been gradual onset of hypertension at less than 30 years of age, exacerbation of a previously controlled hypertension, disproportionate target organ damage for the degree of hypertension, accelerated hypertension, the onset of diastolic hypertension in older patients, unprovoked or excessive hypokalemia, insomnia or daytime sleepiness, concomitant adrenal nodule, a history of early onset stroke, or a family history of primary aldosteronism. If the answer to all of those is no, then they won't need any further screening. If the answer to some of those is yes, one of the primary screening tests that we recommend is screening for primary aldosteronism. The prevalence of this may be as high as 20% in people who have higher levels of blood pressure, stage 2 hypertension or resistant hypertension. So let's go to the next slide, please. So here's some things to think about in thinking about your patients who might have primary aldosteronism as a cause for their high blood pressure. So use this in people who have stage 2 hypertension that's 140/90 or above, or who have resistant hypertension, aren't controlled on 3 standard drugs. And if they do have an indication for primary aldosteronism screening, in the past we recommended that we stop almost all the blood pressure medicines not to interfere with that test. But the current recommendation is that you stop only drugs that would particularly interfere with that testing. That would be mineralocorticoid receptor antagonist, a drug like spironolactone or pleuronone. And then for those who have a positive screening test, and if you're not sure about how to do that, again, we'll make a copy of the guideline available to you, and you can read about that. But if the patient has a positive test, it's important to refer them to a specialist, an endocrinologist, or to a hypertension specialist or some other subspecialty who can evaluate the patient. Next slide, please. All right, so as we begin talking about lifestyle therapy, here's what I want you to hear clearly from me. This works, but it only works if your patients will do it. And your patients will only do it if they know what to do and how to do it, and if they think you're interested in it. I can't tell you how important it is for the physician to emphasize to the patient that it makes a difference. I can't tell you how many patients over the years of practicing medicine that I thought I'd given up on lifestyle therapy. And then when I was telling them that they were going to need a third drug to control their high blood pressure, suddenly they got interested in reducing their sodium, to reducing the alcohol intake, and blood pressure got a lot better. It works. It does work. Next slide, please. So here's some of the things that we talk to our patients about. Weight loss. Many of our patients in America who have high blood pressure are overweight or obese. And so losing weight reduces blood pressure. There are any number of ways to do that. Of course, diet and exercise are the foundation. There are the new drugs, GLP-1 drugs, SGLT2 drugs are useful for some patients who have obesity in the range of a BMI of 30 or higher. And then for patients above 35, the consideration of bariatric surgery for reducing weight. A heart healthy diet, the DASH eating pattern has been around for a long time. It's really simple. A lot of fruits and vegetables, whole grains, low fat dairy products, and be careful about fat content, saturated fat, especially in the diet. A reduced intake of sodium. This is hard in the way Americans eat. We eat so much of our food, it comes to us as processed food from the grocery store or food that we get at the fast food places or restaurants. But it's important to talk to the patient about reading labels and making healthy choices. The overall goal is less than 2,300 milligrams of sodium per day. That's about a teaspoon of salt per day. That's not added salt. That's a total of a teaspoon of salt. But the ideal limit would be even less than that, 2/3 of a teaspoon or 1,500 milligrams per day. Next slide, please. We have for the first time a recommendation for consideration of using a salt substitute, one that is a potassium enriched salt substitute. You get both the benefit of the increased potassium and the benefit of lower sodium intake as well. And then enhanced intake of potassium in the diet, foods that are high in potassium. And then another new recommendation about alcohol. In the past, we've said men no more than 2 drinks per day, and for women, less than 1 drink per day or 1 drink a day or less. And now, for the first time, we say, and it's based on strong evidence, that the optimal goal is abstinence from all alcohol products for best control of blood pressure. Next slide. And then exercise is important. All 3 forms of exercise: aerobic, dynamic, and isometric resistance. Next slide. So here's the take-home message again. High blood pressure is the most prevalent and modifiable risk factor for the development of cardiovascular disease, all kinds of cardiovascular disease, for dementia, and for chronic kidney disease. And we need to get blood pressure down to at least 130/80, and if we can, to less than 120/80. So thank you again for participating in the webinar today. I'm going to pass this over to my friend and colleague, Dr. Adam Bress, who's going to talk to us about pharmacy.
Thanks so much, Dr. Jones. It's wonderful to be here today. Thanks for the invitation, the American Heart Association. And I'm going to talk about the most important pharmacologic therapy points in the 2025 ACC/AHA BP guideline for rural implementation. And before I begin, I'll highlight 4 points that I think, or 4 take-home messages. Number 1 is start combination therapy earlier, especially in individuals with stage 2 hypertension or SBP greater than 140. And the typical first-line pairings are an ACE or an ARB with a calcium channel blocker, or an ACE or an ARB with a thiazide diuretic. And this matters for rural care because the evidence showing that fewer visits are needed for stepwise titration, faster time to control, and less clinical inertia when provider access is limited. And the second point is to utilize single pill combinations wherever possible. There's about 29 single pill combinations, between 13 and 15 for these ACE or ARB CCB or ACE or ARB thiazide diuretic combinations. Again, they improve adherence, they accelerate control, and they help produce more sustained and persistent blood pressure reductions. So it's one of the most important operational recommendations in terms of rural implementation because of perhaps long travel time to clinics, medication adherence challenges, and pharmacy access. So with that, I'll start with 2 important points as we go through my slides. Next slide, please. So as Dr. Jones mentioned, I just wanted to highlight the treatment goal as recommended in the guidelines is a systolic blood pressure target of less than 130 and ideally to less than 120. Okay, so to target and reach, achieve, and sustain these lower treatment goals, more aggressive implementation, utilization of both lifestyle and pharmacologic therapy is needed. And the yellow highlight here is a new recommendation, which is ideally or encouragement to get to less than 120. And there's over 5 randomized trials now showing the incremental benefit in terms of cardiovascular disease and mortality for treating to less than 120 versus less than 140. Next slide. I mentioned the single pill combinations. Okay, this is a recommendation in the guidelines as a pillar of what kinds of strategies we can be using to help improve medication adherence. Single pill combinations also help facilitate once daily dosing. And I mentioned there's over 29 combinations, many of which are available at lower cost. And there are other interventions as well to help patients with adherence. And these are listed in the guidelines, including education and coaching, managing comorbid anxiety and depression, home blood pressure monitoring, reminder aids, etc. So a focus on strategies, durable strategies to improve medication adherence at the point of care is an important aspect of the guidelines as it relates to rural implementation. And one of the main take-home messages is combination therapy, and particularly single pill combination therapy. Next slide. This is the treatment algorithm for initiating antihypertensive therapy. I want to start with this blue panel on the right that kind of spans all of the blood pressure levels, which is, if you look on the far left, top to bottom, it has stage 1 hypertension on the bottom, which is a systolic diastolic of 130 to 140 or 80 to 80 or 90. And lifestyle approaches are recommended for everyone. Okay. And looking at the top, for patients with an SBP of 140 over 90, so stage 2 hypertension. This gets back to what I was saying earlier. The recommendation, class 1 recommendation level, high level of evidence is initiate 2 or more antihypertensive medications, ideally with a single pill combination. Okay. So this is especially important for rural implementation. For those with stage 1 hypertension, the initiation strategy depends on comorbid conditions and or the predicted cardiovascular disease risk using the PREVENT equations. So starting with this first box under the stage 1 hypertension, so does the patient have existing cardiovascular disease, so coronary disease, stroke, or heart failure? And if yes, then you initiate a evidence-based pharmacologic therapy. If the patient doesn't have CVD, but they do have diabetes or CKD, then yes, you initiate pharmacologic therapy. And the patient doesn't have any of these, then you use the new PREVENT equations, which is there's a calculator online in several places, including the American Heart Association. And you type in characteristics of the patient and you get a predicted value for their 10-year risk of cardiovascular disease. And if that's greater than 7.5, then you initiate. Okay. And if none of these, the guidelines recommend 3 to 6 months of lifestyle interventions. And after a trial of that, if the blood pressure still remains above 130 over 80, then you initiate antihypertensive therapy. Okay, so this is the general treatment algorithm for how and when to initiate antihypertensive therapy. Next slide. In terms of what drugs to use, the core first-line drug classes remain simple and widely generic. The first-line antihypertensive classes remain ACE inhibitors or ARBs, thiazide or thiazide-like diuretics, and long-acting dihydropyridine calcium channel blockers, so namely amlodipine. Okay, so the rural implementation implications here are these are inexpensive generic medications that are widely available and we're very familiar with, and they remain the tenets of treatment of uncomplicated hypertension. Okay, next slide. In terms of initial monotherapy versus combination therapy, just to reiterate this, so if you have stage 1 hypertension, so a systolic between 130 and 140 or diastolic 80 to 89, the guidelines do say it is reasonable to start with a single medication with dose titration and sequential addition of other agents as needed. But for everyone else, the guidelines recommend initial combination therapy, ideally with a single pill combination. Okay. And then, of course, do not combine medications where there's either no benefit or harm. And that's most importantly, ACE and ARBs do not go together, or ACE and direct renin inhibitors. ACE and ARBs are direct renin inhibitors. Next slide. So some antihypertensive medication drug pearls. So in general, low to moderate doses maximize the sweet spot between efficacy and adverse events. We do want to think about the mechanism of action of the drugs and underlying drivers of high blood pressure in your patient. Even within classes, there can be some heterogeneity in pharmacology that impacts the efficacy and adverse events. For example, within ARBs, losartan, has a shorter half-life and a less potent on a milligram basis compared to, say, olmesartan or telmisartan. And we'll get into a little bit more of that in a few slides. Next slide. So in summary, you start medication at 140/90 for all adults, ideally combination therapy with 2 or more drugs in a single pill combination. You start medication at 130/80 or stage 1 hypertension for adults at high cardiovascular disease risk or with CVD, CKD, or diabetes. And for adults at lower risk, at stage 1 hypertension, you start medication after 3 to 6 months of a lifestyle intervention. Next slide. So this is another slide just in encompassing the treatment algorithm for initiating medications, and it also applies the level of evidence in the class of recommendations. So we can flip through this animation here just to illustrate that we look at the blood pressure levels, we look at the comorbid conditions, coronary disease, stroke, and heart failure. We also look at CKD and diabetes. And those are the key factors in driving initiation decisions of pharmacologic therapy, combination therapy, and lifestyle interventions. Next slide. Another important change in the 2025 guidelines is the removal of race-based treatment recommendations. So race is no longer used to guide blood pressure medication initiation choices. Evidence over the last 10 years has shown that race has really limited predicted value for antihypertensive treatment response. And there has been no evidence that's shown that using race to guide antihypertensive therapy has improved disparities in blood pressure control. So therefore, race-specific treatment recommendations have been removed from the new guidelines to simplify and improve hypertension care. Next slide. Again, there is a stronger emphasis on adherence strategies and single pill combinations. This is a critical point, especially for rural implementations. Guidelines recommend single pill combinations for most patients with stage 2 hypertension and many with stage 1. And this is based on the evidence that simplifying regimens, especially combination therapy into single pills, improves adherence and time to blood pressure control. Next slide. And this is what the actual recommendation looks like that I mentioned before. So it's a class 1 recommendation and a level of evidence A. So for adults initiating antihypertensive drug therapy, the initial recommended classes are either a thiazide diuretic, a long-acting dihydropyridine calcium channel blocker, or an ACE or an ARB is recommended as first line. Next slide. In terms of the recommended diuretics, these are medications that we're all familiar with that have been available for many years. So chlorothalidone, hydrochlorothiazide, and indapamide. The guidelines does not make a preference over the one over the other. They each have nuances in terms of their potency and in some cases their cost and availability. Chlorothalidone does have a longer half-life and is more potent on a milligram to milligram basis than hydrochlorothiazide. And for these drugs, of course, monitor for hyponatremia and hypokalemia, as well as glucose, uric acid, and calcium levels. Next slide. In terms of ACEs, there are, I believe, 9 ACE inhibitors currently on the market. They're widely available. Historically, the lisinopril has dominated clinical practice. We don't use these drugs in combination with ARBs or direct renin inhibitors. As we know, there is an increase in potassium, especially in patients with renal dysfunction. We know the risk of cough that occurs in 20 to 30% of patients, and of course, angioedema and life-threatening angioedema that can occur in about 1 in 1,000 patients. And of course, do not use in pregnancy. Next slide. There are 8 ARBs, very similar clinical pearls than ACEs, except they do not carry nearly the same risk, if at all, for cough, and that's the main benefit of ARBs. And one of the kind of main selling points of ARBs is when you look at the randomized evidence of ARBs versus placebo, they're pretty much indistinguishable in terms of side effect risk. And the dosing is available here. Okay, next slide. Amlodipine is the main dihydropyridine calcium channel blocker we've all used over the years. It's very simple and straightforward. As we know, there is a dose-related lower extremity swelling, which is more common in women than men, which occurs in between 10 to 30% of patients. And that can be ameliorated with combination therapy with an ACE or an ARB. Next slide. And again, I wanted to just show the level of evidence and the class of recommendation around combination therapy. So it's a class of recommendation 1, level evidence of B with randomized evidence. So in adults with stage 2 hypertension, it is recommended to start with a two-drug therapy in a single pill combination. Next slide. This is mostly for reference, but I've already mentioned this a few times, but there are I believe the latest number is 29 fixed dose or single pill combination products that contain ACE, ARBs, and thiazide diuretics, ACE, ARBs, and calcium channel blockers, as well as there are now 3 triple drug combination products. Okay, many of these are available at low cost, so I encourage you to look them up and get familiar with ones that make the most sense for you and your patients. Next slide. Next slide. Next slide. These are the ACE and calcium channel blockers. Again, another set of calcium channel blockers. Next slide. So there are a lot of combination products. There are some limitations in the availability of the combination products, like for example, products with longer acting or more potent diuretics like chlorothalidone. But there are a lot of products out there, 29. I mentioned the strategies for improving adherence. Here they are again in a table form, and I want to highlight the single pill combination therapy rather than separate pills. Next slide. Okay, we've already covered most of this. Next slide. And with that, I want to thank you. Those are the kind of main elements regarding what's relevant for pharmacologic therapy for rural implementation of the guidelines. I think combination therapy, single pill combination utilization, and a focus on medication adherence. And with that, I'll turn it over to my esteemed colleague, Dr. Commodore-Mensah.
Great. Thank you so much, Dr. Bress. Good afternoon, everyone. My name is Yvonne Commodore-Mensah. By way of background, I'm a professor and associate dean for research at Johns Hopkins, but I started my career as a cardiac nurse and have since transitioned to conducting trials, specifically looking at how we might use implementation science. So meaning taking the evidence that exists in terms of improving cardiovascular health and translating this evidence into real world settings. And we're currently conducting 2 trials. One of them is linked BP and the other is linked hearts. And for both trials, we are partnering with a health system called Choptank Community Health on the eastern shore of Maryland. And through this work, I have seen firsthand the realities of hypertension management and prevention of hypertension in rural settings. So I'm really honored to be invited to speak on the issue of team-based care and a plan of care for hypertension in rural settings. Next slide. So this is a framework that was developed by Dr. Tom Frieden and colleagues that talks about blood pressure control globally. And I think all of us are here on this call today because we care about blood pressure control. But the reality is that there are a lot of hurdles to achieving blood pressure control, and these hurdles are organized under diagnosis, treatment, and continuity of care. Now, let's take diagnosis, for instance. We know that a major challenge is that we don't have a sufficient health workforce to manage the growing burden of hypertension. Now, if we reflect on this issue, we know that there are almost 120 million US adults who have hypertension. So the burden of hypertension is so high, and we don't have enough healthcare professionals. When you think about treatment as well, we need clinicians to treat hypertension. We don't have enough. There's a persistent shortage of primary care providers in urban and rural settings as well. And also for continuity of care to attain blood pressure control and maintain blood pressure control, again, we need healthcare professionals to do this. And so when you look at this framework, it's clear that one of the persistent challenges is a limited health workforce to manage the burden of hypertension in the US, but also globally, we know that there are 1 billion adults who have hypertension. Next slide. So, what is team-based care? So, team-based care is a health system level intervention. When we think about the barriers to blood pressure control, we know that there are patient level barriers, there are provider level barriers, but there are also health system level barriers. And team-based care is a health system level intervention that relies on multidisciplinary team members. So, some of you may have heard the term task shifting or task sharing. I prefer team-based care because it acknowledges that it takes a team to be able to improve blood pressure control. Now, team-based care is evidence-based. There are numerous studies that have shown that the advantages of team-based care include, one, achieving blood pressure control. There are a number of trials that have been conducted in the US and globally that have shown that team-based care works. It improves blood pressure control. It expands healthcare access, especially in the context of rural health. It also helps to improve patient adherence. Patients want more access to healthcare providers, and you can imagine from the standpoint of being a patient, having to wait 6 months to see a clinician. That's not ideal. So this is one of the things that team-based care helps to address. But also the good news is that team-based care helps with addressing clinician workloads. I think we can all agree that most clinicians feel burnt out because of the challenges of providing care in diverse settings. And so team-based care is one of the ways that we can expand the team and be more efficient in how we provide healthcare. And also it's important to acknowledge that patients are happier. There's better patient satisfaction when we do practice team-based care. Next slide. So digging a little deeper in the context of rural health, we know that there are a number of challenges, and I think everyone on this call has a lot of firsthand experience when it comes to the challenges of promoting blood pressure control in rural contexts. We know that there are unique challenges, including limited broadband access. Many of you recall during the COVID-19 pandemic when a lot of health systems pivoted to telehealth. And that pivot was unequal for many health systems where broadband access was also unequal. And so we made a lot of assumptions about who had access to broadband and did not acknowledge or prepare accordingly for patients who did not have access to broadband. We also know that in many rural health contexts, there's a shortage of pharmacy services. And so people have to travel longer distances to be able to get access to their medications. But team-based care helps to address some of these barriers and also allows us to use what pharmacist-led medication titration protocols, and such as the one that Dr. Bress talked about in terms of intensifying treatment, and also community health workers. I'm sure there are community health workers on this call. In our linked BP and linked heart studies, we've partnered with community health workers, and I can tell you they are making a difference in addressing transportation barriers, issues surrounding food insecurity. And so we need to advocate for more supports and reimbursement for the care provided by community health workers as well. and also home blood pressure monitoring. In both trials, we're using home blood pressure monitoring, and community health workers are teaching patients how to monitor their blood pressure at home in order to achieve blood pressure control. Next slide. So what you see in front of you is a figure that denotes what we mean by team-based care. And I think we all know that healthcare is a team sport. And my favorite sport is soccer, or others say football. And you can see here that at the center of the team is a patient. And what's missing here is that the patient also comes from a family and they have a support system. So we need to consider what this unique patient needs in deciding who should be part of the team. Now, as I implied or alluded to earlier, more of our patients need more support. They need access to a registered dietitian who will make concrete what we mean by a DASH diet, how they can adjust their diet to be heart healthier. Patients also need access to pharmacists who will address any issues in terms of access to medications, cost of medications as well. They also need access to a nurse who might teach them how to use a validated blood pressure at home to self-monitor their condition. And we also need medical assistants. Their roles are vital in the trials that we're conducting now. It's the medical assistants who are measuring blood pressure. And so we focus our training on making sure that we train the medical assistants using a standard protocol to measure blood pressure accurately. Next slide. So this table is taken from the blood pressure, the hypertension guidelines. And so it's not meant to be an exhaustive list of the responsibilities of the hypertension team, but a few things I would highlight are one, the use of evidence-based diagnosis and management guidelines, and that's indeed the topic of our conversation today. It's important that the team comes up with a structured follow-up plan and mechanisms to remind patients to monitor their progress in terms of blood pressure control. Patients also need medication adherence support. A lot of patients may forget to take their medications as prescribed, but there are also things that clinicians can do in terms of simplifying the medication regimen. So when we think about adherence and the reasons for non-adherence, sometimes there are things that the healthcare team can do to make life a little easier for our patients as well. And as I alluded to also earlier, the use of evidence-based treatment algorithms. So for one of our trials that we're conducting currently in Ghana and Nigeria, we're training nurses to use a one-page treatment algorithm to help manage blood pressure, because in many African countries, the patient to provider ratio is somewhere in the order of 2 physicians to about 10,000 patients, right? So as we think about access to physicians, it's the situation is dire in rural settings, but globally in some settings, the shortage is even worse. Next slide. And so I've alluded to some of these different roles of healthcare professionals. We know that we need more primary care clinicians, including physicians, nurse practitioners, PAs. We need more of them to be able to diagnose and help manage complex hypertension care. In some cases, it's important to refer to specialists. There are many rural settings where there aren't enough cardiologists in terms of really referring patients for more specialized care. We also need nephrologists, we need pharmacists, and I've mentioned a lot of these different roles, but the point I want to emphasize on this slide is that each person on this team is important and it plays a unique role in helping us to achieve blood pressure control. Next slide. So what you see here are the guidelines as it pertains to team-based care. So team-based care has a level 1 recommendation. It's a class 1 recommendation, and the class 1 recommendation is the highest level of recommendation, meaning the benefits outweigh the risks. And so in this case, we must practice team-based care. So for adults with uncontrolled hypertension, a team-based care approach is recommended to achieve and maintain blood pressure control. But also, we need to implement an evidence-based care plan that involves home blood pressure monitoring. I've mentioned this already, but we also need team-based care that addresses social needs for our patients as well in order to achieve and maintain blood pressure control. We also need a framework. And so without a framework or a plan, we will not achieve controlled blood pressure. And so for adults with uncontrolled hypertension, we need an integrated treatment model that includes all the things that Dr. Jones has talked about in terms of accurate blood pressure measurement. We also need a prompt treatment plan. We need to engage our patients and also employ or use home blood pressure monitoring to ensure that patients are engaged in their care. Next slide. We also need to ensure that there's a follow-up plan after initial blood pressure evaluation and initiation of antihypertensive therapy. So for adults with uncontrolled hypertension who are newly placed on blood pressure medicines, or when there's intensification of their medical therapy, we should have a plan to follow up to ensure that blood pressure control is achieved and to also ensure that there's a plan for maintaining blood pressure control. And the last thing I'll talk about on this slide is technology. And this is one of the lessons we've learned in our work for the Linked BP and Linked Hearts trials. So for Linked Hearts, we have a community health worker, but we also have a pharmacist. And the pharmacist for the past 3 years has worked with CHOP tank patients and partnered with primary care providers to intensify treatment and has never seen any of these patients in person. She's provided all of this care remotely via telehealth. So that's what this slide is really highlighting, that there's an important role of health information technology in terms of improving blood pressure control. The first one touches on the use or the potential of synchronous or asynchronous communication. So synchronous meaning using phone call, video call to follow up with patients, and asynchronous meaning following up with text messages or emails to really answer questions that patients may have. And then also the use of electronic health records for both trials. We identify patients with uncontrolled blood pressure by partnering with the health systems, and in this case, CHOP tank, to identify patients with uncontrolled hypertension. And those were the patients that we wanted to provide support to. And so EHRs are where we can identify the patients who need the most help and connect them to the right resources, such as community health workers and pharmacists. And the last point is that, and this was a class 2A recommendation, that in adults with uncontrolled hypertension, telehealth interventions can be useful to reduce blood pressure and improve office BP control. And we are learning this lesson through the Linked BP and Linked Hearts trial, where, as I mentioned, the community health worker and the pharmacist, they are partnering to support patients, and all of this work is being done remotely. Next slide. And so I'm going to copy from Dr. Jones's approach in terms of the take-home messages. So if there's one thing you walk away with today in terms of my presentation, it's that a multidisciplinary team-based approach is effective in assessing and addressing patient access to medications, and also addressing other structural barriers to support individual patient needs, and thereby reducing these barriers to achieving blood pressure control. And team members may include physicians, it may include nurse practitioners, PAs, pharmacists, the list goes on. But the important thing is making sure that the patient is at the center of the healthcare team. So with that, I'll turn it to my colleague, Dr. Jones, to share a few remarks from his perspective.
Thank you, Dr. Commodore-Mensah. And I did ask for this moment to have a direct message to the physicians on the call. So when this concept was first introduced to me, I was a little bit skeptical. But here are the two things that really made me, and I think since then, as I've worked with many other primary care physicians, made them comfortable with this team-based approach. Number one, the algorithm should be put together under the direction of the physician on the team. All should participate in creating the algorithm, but should be done under the direction of the physician leader. So you have control of what medicines your patients are going to be getting, what type of medicines and so forth, and all of the other things involved in their care. So no loss of control. Number two, I was skeptical that my reimbursement, my revenue was going to go down because I was sharing patient visits with others on my team. But here's what I learned. I have a very busy practice and no shortage of people who want to see me. And so I wound up dealing with more complex patients, higher reimbursement rates than for a blood pressure follow-up. And in the end, better income for the clinic and better income for me personally. So anyway, I hope if you've not done this yet, you'll embrace this concept of team-based care for the benefit of your patients without fear that there's going to be a detriment to you in your personal life and in your professional life as well. So we are happy to have with us today Jessica Weborg, who has on-the-ground experience in primary care in a rural setting, using some of these concepts. And Dr. Weborg, Ms. Weborg, we're glad to have you here.
Thank you, Dr. Jones. I'm excited to be here and talk about implementing all the things that we spent the last hour talking about in real practice. So my name is Jessica Weborg. I am the clinic project coordinator here at Pender Community Hospital District. I have been with our district for 13 years. Our hospital district is located in Pender, Nebraska, with a population of approximately 1,100, located in rural northeast Nebraska, where 38% of our population lives in low population density areas. So we are pretty rural here. Next slide. Our integrated health system is comprised of a critical access hospital. We have 4 rural health clinics, 3 pharmacies, a child development center, and a facility for aging adults and seniors. Our medical clinic offers primary care, maternity and pediatric care, wellness, preventative exams, same-day and acute visits, x-rays, lab services. Most importantly, are my favorite, care coordination, vaccinations and minor procedures. Our hospital is a 21-bed facility which offers behavioral health services, emergency services, OB and maternity care, rehab services, surgery, and outpatient specialties. Next slide. Our medical clinic committed to improving overall hypertension management in 2023. This initiative was part of our quality project through our ACO, Bryan Health Connect. We received direct support and guidance from the American Heart Association through Senior Rural Health Director Tim Nicolai, who was a tremendous help in providing the structure for our Target BP program. We built our hypertension management policy with that support through Tim and our ACO. Staff training, including annual competencies on measure accurately, cuff calibration, and orthostatic training has kept us consistent with our expectation of these processes. Measure accurately has been a primary focus as this impacts all other aspects of our disease management. Monthly data collection, which is primarily what I do with performance review, is completed with key staff along with all of our care providers. Each provider is given a detailed scorecard with specifics of each patient that failed control and any intervention that was made with that visit. We found 2 of our most impactful tactics are self-monitoring, which we've talked a lot about today, and patient outreach with our care coordination team. We are able to offer multiple forms of self-monitoring to our hypertensive patients. Initially, we started with grant funding and quality initiative dollars to purchase and create a sustainable access for SMBP. We utilize remote monitoring devices, which are provided to patients undergoing chronic care management. These readings are also reviewed within our health coach office and primary care provider several times weekly. We are also able to provide validated take-home monitoring devices off of the validated machine list or device list, rather. These are given out to patients who are unable to afford home monitoring units and individuals who may struggle with adherence in carrying out home monitoring. These devices are offered at no cost to our patients, and our staff have been trained also to calibrate home devices by utilizing our AMA device calibration test tool. A series of blood pressures are taken with the home device, and we cross-reference to ensure that variance is within an appropriate range. We encourage patients to bring in their devices during their annual physical or any time to have a nurse calibrate their unit. All options are available to patients along with education on how to measure accurately. This education is presented or completed by our health coaches with recommendations on twice a day readings, 2 in the morning and then 2 in the PM for a minimum of 7 days, along with review from the primary care provider. Our health coaches assist in carrying out our committed Act Rapidly protocol, providing patient outreach, education, and provider-directed follow-up. Outreach is being done monthly on all patients who are found to be above target level, with focus on patients who have had medication adjustments and newly diagnosed hypertensive patients. We utilize a clinical pharmacist to engage patients in medication adherence. Through building our policy, physicians committed to utilizing that AMA hypertension medication treatment protocol, which has made our guidance in medication management very clear and understood by all clinical staff involved. Our clinical pharmacist also reviews the performance monthly according to that treatment protocol. Within our program structure, we committed a physician champion to speak to Dr. Jones's point. Together, he worked with his partner to commit to a treatment algorithm that they were all comfortable with, and that set the framework for our program. And then he also reviews my monthly data to ensure that his partners are committed to that protocol and we're utilizing that tool appropriately. He's also a great reference to practice partners and gives feedback monthly. Next slide. And this is just a very similar graphic to Yvonne's team-based approach. Each person in this team approach plays a role in management of chronic disease. Our excellent performance is due to the consistent efforts of this team. Having provider buy-in was huge for this project and our ongoing success to maintain high performance. Next slide. So to talk about some of our challenges and opportunities realistically here, really, a few challenges we have experienced and continue to experience with hypertension management. We invest a great amount of time in patient outreach and often do not reach the patient or have trouble with realistic adherence to our treatment plan. Probably even more so is staffing our health coaches and our clinical pharmacists in rural areas. As we have staff looking to retire, we often have to plan well ahead. These positions are critical in providing the patient outreach and care coordination to maintain our success in this program. If we lose a health coach or a clinical pharmacist, sometimes those positions remain open for months without much interest or applicants. And that's a kind of a gap in that team framework where others have to pick up that burden. Opportunities, I would really like to see our health system invest in expanding remote patient monitoring and ultimately successfully integrate those readings directly into the EHR for immediate clinician review. Quite a bit of that is manual, unfortunately, for us here. I would also like to see this type of framework be implemented into other chronic conditions, such as CHF, COPD, and asthma. So we're working on that currently. Next slide. So impact here. At the beginning of this project in 2023, our baseline control rate for hypertension was at 70%. We steadily improved this control rate and remain consistently above 80% control. We did achieve the Gold Plus Target BP Award in 2025, which has given us an opportunity to showcase our great care and focus on hypertension here in Pender. We have successfully partnered, I like to think we've successfully partnered with patients in supporting their role in chronic condition management. As we partner with our patients, they build the confidence in managing their blood pressure. And then one other unique win I'd like to talk about is our administration has committed to making hypertension management performance goal incentivized, which is unique. This allows staff in our district to be financially rewarded when performance goal is met. So this means that our hypertension goal was set at 80%. And if we meet that goal at the end of the year, we are paid out across the entire district a financial bonus, which I think is pretty unique to have that level of buy-in at the administrative level. And then, of course, we're meeting our ACO goals. So we're able to increase our shared savings dollars. So that's very exciting as well. I'll send it back to Eduardo for any questions.
Miss Weborg, Nurse Weborg, that was outstanding. And congratulations to you on outperforming most everyone else at 80+% for a number of years. Y'all are setting the bar and serving as a model and an example to others of what can be accomplished. I do have a couple of I have one question for you, and then there's some questions, some really good ones that have been asked that we'll try to answer. We've got some time. I was getting nervous. I'll be honest with you, I was getting nervous. I thought we were like ending at the top of the hour, and thankfully I got a text that calmed me down. I'm wondering, what do your patients value? And do they get a sense of the success that you are having compared to your peers? So what do they value, and do they know how y'all are doing?
Yeah, as a nurse and seeing just this whole evolution of this robust treatment program here in Pender, I think patients value that care coordination from the health coach and the clinical pharmacist. I think often patients have a lot more questions than we anticipate. This is all very everyday type of work for us. So to be able to have access to a nurse that knows all things hypertension and then having just that clear treatment protocol gives us the ability to be confident in directing that patient. I think that's unique too, to get physicians all on the same page, to be able to do a chart review and understand what's the next step for that patient, and then partnering with that patient, giving them the tools of SMBP is huge, because then you're not regurgitating to them. They get to have a seat at the table, provide those readings, understand what's being asked or partnered with of them. And I think that's just huge. And I'm very thankful that Pender's able to have as many health coaches as we do, because they are just worth their weight in gold in coordinating that care.
Let's give a follow-up question. When you talked about challenges and opportunities, and I think they resonate with all of us, irrespective of where we are. These are challenges. On the opportunities, I love the idea of remote patient monitoring and figuring that out. And then on the second part, growing other chronic condition management. I'm just wondering if y'all have thought about and have experimented with, I don't know, remote health coaching. And maybe y'all are already doing that. Just wondering, certainly during COVID, we learned how to do a lot of things remotely that we never thought we could do remotely. Just wondering if that has played a role.
Yes, certainly. And a lot of wild things are happening here in Nebraska, as I'm sure each state, with these rural transformation funds and just pushing us outside of our thinking and how to provide more for our patients in care coordination is our primary focus. So certainly looking to be creative through 2026 and into 2027. And the chronic condition we're really looking at is COPD management, which we all know requires a tremendous amount of care as well. And how can we do that in a similar fashion as we have with hypertension management?
Thank you so much. That was tremendous. And again, congratulations.
Thank you.
I'm going to ask questions, and some will be directed and others will be whoever wants to raise their hand and answer the question. The panelists thought, Dr. Jones, you would be best to answer this particular question having to do with a patient whose systolic blood pressure is under 130, but whose diastolic blood pressure continues or is consistently between 80 and 90. How might participants, viewers, think about this particular situation?
Yeah, that's a good question. You know, we just talk about systolic blood pressure so much these days and rarely think about or talk about diastolic blood pressure. Part of that is because most patients who have hypertension driven by their systolic blood pressure, and the systolic is usually the harder to control, and if it's controlled, the diastolic is usually controlled. A big exception to that is young men, particularly young African American men who are overweight. We often see in this patient demographic patients with normal systolic blood pressures, but quite elevated diastolic blood pressures with a narrow pulse pressure. So the answer is to continue to increase your therapy, whether that's lifestyle therapy, and that's important to not forget that one as a way to get that diastolic down. Lifestyle therapy plus medication therapy, and there are no particular medicines that work better on the diastolic. But here's the thing that's critically important is there's not risk for the patient in getting that pulse pressure lower by extending antihypertensive medications. Go ahead and treat the patient with more medicines to get their blood pressure below 80. It's an important marker for safety for the patient. But I'll tell you, from my experience, these are tough patients to treat. Thank you for the good question.
One of the other questions here is about the recommendation on the blood work that's done. So you diagnose somebody, you do the lab panel, you get a set of results. How often should that be repeated? And or which of those tests should be repeated and how often?
Yeah, so I'll take that one as well, and let my colleagues add to what I have to say. So we do have a standard to begin with this panel at the beginning of evaluation of the patient. We don't have a specific recommendation about follow-up because that's so individualized depending on the patient, their other medical problems, the medicines that they are taking. So if I began a patient on medicines and a diuretic is one of them, or an ACE inhibitor or an angiotensin receptor blocker is one of them, then within 2 to 4 months, I do a follow-up set of electrolytes and creatinine on the patient, remembering that if you're starting them on an ACE or an ARB, that at that 2-month follow-up, they may have a little bit of a bump in their creatinine because that's one of the ways this medicine class works. And so just electrolytes and creatinine at 3 to 4 months on everybody that's taking a diuretic, an ACE, or an ARB. If you prescribe a calcium antagonist, I think you can wait a year before you repeat those things. And I do think everybody at least once a year needs to have electrolytes done, a creatinine done, a glucose done. The lipids, it's based on what their initial one. If they've got an absolutely normal lipid profile, may not repeat that for 3 or 4 years. Anybody want to add to that, guys?
Well, I will move on then. There are some specific questions in the Q&A to some of y'all, and I'm not gonna ask those. I'm gonna hope that you will answer those on your own, having to do with vendor relationships and or partners that you might be working with that I think are maybe best addressed one-to-one. So I keep thinking about and all of y'all touched on an aspect of this. Time is a very limited resource, not only for those of us who have busy jobs and think we're important, but also just for all of us who live our lives. There's only 24 hours in the day, and there's only so many minutes in that day to do things. And in rural parts of the country, maybe more so than in other places, travel time is a significant challenge and a significant user of that currency of time. Each of you mentioned a strategy, but I'd love strategies or a strategy. I'd love each of you to specifically think for a second here. Is there one or two things that you think can, from the perspective of the patients and the clinical care team, be a strategy that results in optimal blood pressure control eventually, while thinking about how to minimize the amount of time that the person has to spend getting it done, not in the name of doing physical activity or eating healthfully, but in the name of sitting in a car or sitting in a waiting room and not necessarily feeling like there's a return on that investment? That's a loaded question, but what, again, just to reemphasize, what are those things that we can partner with our patients with that they will see value and we will see value, either from the clinician perspective or the societal perspective? Better blood pressure control is a public good. I'm going to go, maybe I'll start with you, Dr. Commodore-Mensah.
Yes, I'm happy to start. I'll say that for our trial with the Chop Tank Community Health System, the first time I had to drive to visit one of the sites on the Eastern Shore, which is about, I'll say, 2.5 hours from Baltimore, I was able to see firsthand the experiences and the challenges of actually showing up in person to the clinic to have your blood pressure checked and to have your treatment intensified. For our trial, I'll share that we thought it was very important for the community health worker to meet with the participant or the patient in person for the first visit, to sit with them and teach them how to use a home blood pressure device, to teach them how to use the mobile health application and explain how the device works, answer any questions. And all the other visits after the first intervention visit is all done remotely. And I think that definitely helps to overcome a lot of the barriers that we've talked about in terms of transportation. And the reality is that for the average adult, most people are juggling a lot of different roles. In addition to, working, a lot of adults are caregivers. And so we think about how inconvenient it may be for someone to take time off for a 15-minute visit. And you compare that to the 1 hour that they may get with a community health worker or a pharmacist who's explaining how medications work. So that's not to say that it's not important to be seen in person, but I think we need to find a way to really optimize or make care more convenient, because the current model is not convenient for the average person to take time off for a chronic condition that they'll have for the rest of their lives. So really trying to find a way to reserve, in-person visits for things that require being physically in the office, but leverage really home-based, care that is delivered by other members of the healthcare team.
Bress, a thought on that?
Thanks, Eduardo. I think it's a great question. I think the thing I would throw out there is the promise of home blood pressure monitoring or self-measured blood pressure, especially combined with self-titration. As we know, simply giving patients a home blood pressure monitor to measure their blood pressure, there's randomized evidence that that intervention reduces clinic blood pressure alone. But when you add on medication titration, with telemonitoring, with the healthcare team or team-based care and clinical support, the effects on blood pressure and blood pressure control go up. So the costs of validated kind of easy to use home blood pressure monitors have come down, and the technology have come up in terms of the ease of integration with phones and Bluetooth and ability to track readings more easily. I think that's probably one of the most important tools we have for providing, high quality care to all patients, and even more so for patients with long drive times and low geographic access to care.
Appreciate that. I'm going to shift, Dr. Jones, because I think there's a question that's a natural shift that's in the Q&A, and that is that it can sometimes be, I think it's really important for us to remember that home blood pressure devices and home blood pressure cuffs are two different things. The cuff is what you use with the device. But one of the questions is about how difficult it can be sometimes to find the right sized cuffs. And the question was, do we ever recommend forearm blood pressure measurement as opposed to upper arm blood pressure measurement?
Yeah, good question. And the ideal is to find the large cuff. That's by far the best thing to do. I don't want to. I don't want to be advertising a brand, but there are some one or two brands and models within the brand sold at most pharmacies or box stores that sell several sizes of cuffs. The instrument comes with a standard size cuff. Online, you can either order the larger cuff, or you can order the monitor with the larger cuff online. And again, I'm going to be careful not to offer any brand names, but you can find that information with a quick internet search. And so I do strongly recommend that your patients with large arms get a large size cuff. Now, some of your patients have such very large arms that the upper arm has a shape. They're shaped like a cone, and it is very difficult to measure blood pressure on a brachial artery on those arms. And in that circumstance, the forearm blood pressure, where you put the cuff on the forearm and listen at the wrist level, is an acceptable way in a very obese patient. It should not be the standard way to do with a standard cuff. You should first try to get the largest size cuff available, use it for the upper arm if you can, and if that doesn't work, then use the lower arm. Try to find that right position for the arm that you're getting, that part where the blood pressure is being measured at heart level.
One more. This is an extension, so we're going to go further down the arm, which is, would you recommend, or what about wrist cuffs? They are out there for those who can't find their size, and I probably know what the answer is, but don't know for sure.
Yeah. So generally, the answer is an absolute, very strong. I won't use colorful language. Just no. The exception to that is what I just mentioned. The patient who has an extremely large upper arm that is cone shaped, that you simply can't get a cuff around to measure in a reasonable way. There are some wrist devices. They're not as part of watches. They are an inflatable device on the wrist or the forearm that can be used in those circumstances. None of the commercially available watches that purport to measure blood pressure or to report hypertension are useful to use. In fact, they're dangerous to use because they are giving false reassurance to your patient. So we should discourage the usual watches that purport to measure blood pressure on the arm or wearable devices. But there are some wrist monitors made by reputable companies for patients who have severe obesity and can't be measured any other way.
Thank you. I want to remind everybody that the other very, very important factor having to do with devices is that you use in your practice and those that get recommended for home be validated devices. Validatebp.org has a list of those. We're coming to the end here. So I'm going to ask each of you to spend, I don't know, 30 to 60 seconds. What would be, and y'all all did this, but I find and have found through life, repetition is a beautiful thing. It helps things crystallize in your brain. I'm going to go in reverse order again. So Dr. Commodore-Mensah, then Dr. Bress, then Dr. Jones. What you think is the one takeaway that people should leave with so that they each, you know what, and Nurse Weborg, you as well. So the four of you, we have enough time. You have 1 minute. And what's the one thing so they leave with four things? Hopefully they'll be able to do three of those four and things will move in the right direction. So Dr. Commodore-Mensah first.
For me, it would be team-based care is a class 1 recommendation. We should work together as a team and provide more support to patients and do everything we can to make sure every member of the healthcare team feels valued and makes a meaningful contribution to improve blood pressure control.
Thanks. For me, for
Bress.
rural hypertension care, I think to add on to Dr. Commodore-Mensah's, the most impactful strategy is using simple, standardized treatment protocols in a team-based care framework that incorporates early combination therapy with single pill combinations, so blood pressure can be controlled quickly and consistently, despite challenges in rural environments.
And explicitly, I think I heard in some form or fashion to include pharmacists, PharmDs as part of the team, and to include community health workers, CHWs, as part of the team.
Thank you, Eduardo.
Just making sure I heard it. Dr. Jones.
So you've given me a minute, so I'll do two. One is to remind you that beta blockers are not a part of the recommended drug classes for primary prevention of cardiovascular disease in patients with hypertension. Beta blockers are only used in very special circumstances in patients who already have heart disease and can be useful in lowering blood pressure, but they are not part of the four classes that are recommended for most patients with high blood pressure for primary prevention. Those were used in the past, but are no longer recommended for good reason. Number two, 130/80 saves hearts, saves kidneys, saves brains, reduces the risk of dementia. 130/80, it works, it's good.
Nurse Weborg.
Yeah.
You get to close us out.
Oh, I hope it's good. I would find a physician champion. That was a key to our program structure if we're discussing that. And then build that structure with a willing, capable team and make that framework clear and understood so you can partner with patients and make control happen.
So that was tremendous because we still have a few seconds. And I want to thank the panelists, of course. Y'all were awesome. I want to thank the participants. Y'all asked really great questions, and the close to 300 or over 300 of you stayed with us. So here's some information. We're here to help, to access tools, connect you with data submission, and then down the road to celebrate your team's success. So with that, again, a thank you and a thank you. An additional thank you to all the folks at the American Heart Association and at Target BP that made it seem like Doctors Jones, Bress, Commodore-Mensah, Nurse Weborg, and myself knew what we were doing and how to do it. So thank you all. Have a great rest of your afternoon.